Good afternoon, everybody. We're just going to wait for a few people to join up, and then we'll get started in about 3 or 4 minutes. So just while we're waiting, a little exercise. If you could use a chat just to share maybe one word or maybe 3 words that comes to mind when we're talking about trying to implement change. So if we've got something new that we want to try out in an area with some other staff, what comes to your mind first? What 3 words? Persistent, opportunity, challenging but exciting, resistance. Yep, lots of resistance. That's right. Yeah. How hard this is going to be. I think I probably resonate with that. My first sort of reaction is slight dread, because I know how long and hard it is, and how it feels like you're getting nowhere for a long time. But then magically it starts to actually gain momentum, and that feels really good. And I guess that's what we're talking about today: PDSA cycles, and how to change that sort of feeling of inertia and a huge obstacle into something that actually is momentum and moving forwards. And that's the whole challenge. So by trying to break it down into a manageable process such as PDSA, it hopefully takes away a lot of that challenge, that resistance, that difficulty. Good. We're just wait another minute, and then we will get started. For those who've just joined, we've been sharing in the chat, what 1 or 3 words that comes to mind when it comes to implementing change. If you can share that in the chat, that would be great. Okay, so this session is on testing and measuring changes, and we'll run to about 5 to 2. So I'm very grateful for you guys lending me some of your time. I'm just going to share my screen now. So let me know if you can't see that. So yeah, we're going to go about look at the PDSA, and we're going to find out how we need data to really power our PDSAs, and how to plan our PDSA cycles. So we'll be looking a little bit about planning data for collection, how to sample, a little bit of run charts, which you'll get a lot more of in the next month or the next module, wherever you are at in your online learning, and how to link those tests of change to build belief. So a lot of people focus on quality improvement and how it's not research. whenever you come to somebody who wants to provide resistance against your project or something, they often hide behind or retreat behind the familiar fortress that is evidence. And typically people who do that do not have a good appreciation for the difference between quality improvement and research. And the biggest culprits are probably doctors, because your doctors have been trained right from the beginning about evidence-based medicine and what it involves in doing trials and other such research projects in order to get enough evidence to show that what your treatments are doing are actually doing what you think they're doing. And they apply the same lens to everything else. And so when it comes to getting evidence for a particular change in healthcare, it's, typically follows the same model of research, which is where you try and control all the biases and all the confounders in order to see whether the thing you're changing actually is making a difference or not. So one big barrier to get over is that sort of difference between research and quality improvement. I remember one time I was trying to convince a GP who ran an urgent care center to put a healthcare questionnaire into their waiting room, the health lifestyle questionnaire, and it was a sort of an interactive thing to get people to see how healthy they were exactly and where they might improve their actual health. So it was not disease focused; it was actually health focused. It was a sort of a health holistic well-being sort of intervention thing. And he came at it from a real research lens and shot me down because of the way I presented it in the plan to him based on a sort of quality improvement project charter. So you either try and convince the person that they're wrong, or you pretend that they're right and you change your document. So I changed my document. It took me about an hour. And I was basically saying exactly the same things, but in just a format that he understood in a sort of a research lens. And he came back to me and said, "This is wonderful. You've changed it all and it looks perfect now. I can agree to this." And I hadn't actually changed anything really. So knowing your audience is really good. But if you can convince people that actually when you're doing quality improvement, you're not trying to prove something. You're just trying to gather enough data to inform your improvement, to let you know that things are going in the right direction. That's the whole crux of it. So we've been over this before. There's 3 types of measures: outcome, process, and balancing. What we introduced now in this lecture is the unambiguous operational definition. So that is a definition that we can use to accurately measure that measure that you've defined. So how you do it, exactly what you measure, how you measure, where you measure, by whom, by what method, etc. Because that's going to make it repeatable. You need to be able to give this set of instructions to somebody and go off and be confident that they'll come back with exactly what you're thinking in terms of data. And there's 2 levels of measures. There's a project level measure, which kind of informs your overall project. It's usually an outcome measure. And then there's PDSA level measures, which help you understand if what you're testing is actually happening. So they're usually process measures. Just for this one, for each one in the chat, if you want to just say what type of measure it is and the level each measure is in this QI project. So the type of measure is outcome, process, or balance, and the level would be project or PDSA level. So if you can, just for each of those 1, 2, and 3 there, just put in the chat what you think. So for those of you just listening, perhaps the first one is rate of occurrence of MRSA per 1,000 patient days. The second one is percent of patient encounters with compliance with hand hygiene procedure. And the third one is number of hand sanitizer stations available. Okay, so Sam says the first one is outcome and a project level measure. Second is a process PDSA level. And third, maybe a balancing. Okay, let's see what the answers are. So yeah, the first one is a project level and it's an outcome measure. If that happens, that's what we want to achieve. So that's a good outcome. And yep, it's what the project would go on about. So that one is straightforward. The second one, process level, process measure and a project level. Okay, but it's also at a PDSA level and an outcome measure. So at a project level, the objective is really to reduce transmission of infections. So it's not an outcome measure at the project level, but at the PDSA level, you might be doing something that specifically targets hand hygiene, like asking people to wash their hands more. So that is the outcome of the PDSA level. Okay, and the last one is a PDSA level process measure. Okay, so your first test is to try and improve hand hygiene by increasing the availability of hand sanitizer. That is not the end. So getting availability of hand sanitizer is definitely a process measure, and it's something you do at the PDSA level because you might not continue measuring that ad infinitum. Okay. So how would you measure this outcome? So just have a think to yourselves. How would you measure this? Because this is quite woolly, isn't it? Access to healthcare. So how would you go about sort of answering that question? Well, you might need to think about first about what is the definition of access and what is the definition of healthcare. You could be narrow in your healthcare definition as anything delivered from, I don't know, the hospital or Southern DHB. Or you could be much broader and say healthcare is any sort of interaction between person of the community and a service, be it voluntary or commercial, that has some positive impact on somebody's health. So there's a whole sort of question there. And access, what is access exactly? Is it the ability to consume, or is it the ability to is it just an awareness of all this stuff, or is it to do with financial access? Is it free, or is it means tested, or is it private? So here they say there's a number of ways to measure access. You could have some hard measures such as number of days to the third next available appointment. So that's kind of a proxy measure of how empty somebody's diary would be in a clinic. Number of minutes from time of appointment to time to see clinician. So that's like a waiting time sort of access measure. Percent of good or very good answers on relevant patient satisfaction survey questions. Because of course, some people have tolerance for waiting longer than others. And at the end of the day, I guess what we want to do is meet the expectations of patients. And so that might actually help there. And then average daily clinician hours available for appointments. Again, is another sort of hard measure. They all kind of measure access in different ways. And there's probably no one super measure that would be able to tell you the whole picture. So which one of these is an operational definition? None of them are really, because there's still questions when you read these. For the first one, how do you define the occurrence of MRSA? Is it positive positive cultures from the laboratory? Probably in that case. But how do they measure it? Is it a swab, or is it blood test we're talking about? These are all things that need to be defined. Just got some background noise there. Let's just try and mute some. If everybody could mute themselves, that would be great. Percentage of patient.
On this module already, it doesn't actually.
I'm just going to have to try and find the mute button. Come on.
So are you going to Monaco today?
I'm just going to try and, oh, sorry.
I want to.
There we go, found it. Right. So yeah, percentage of patient encounters in compliance with hand hygiene procedure. Again, how do you define a patient encounter? Is it one of the 5 moments? How would you calculate the percentage? What's the denominator? And then the hand sanitizer stations, are you including the counter stations, but some of them might be empty, so what is available? Anyway, these are all things that you think about in a definition to make it truly easy to measure for anybody. So these are the key questions. You're going to think, what data you're going to collect, who's going to collect it, how often will be collected, and how will it be collected? And also simplicity, of course, is the key thing. If it's a very difficult thing, then you're going to get junk data back. You need to make it easy. So one way you can make it easy is by actually reducing the amount of data you need to collect by not collecting everything. And I think this is something that's underutilized. You know, when we think about our projects, we just think about measuring everything coming through at one point, and we don't actually think, okay, we'll just take a random sample and use that instead. You typically only need about 30 data points for quality improvement. So quite often our processes are much bigger than that. So you can think about sampling. Judgment sampling at the end there is slightly hocus pocus. So that's to do with something that's rare and not easily defined. And the only way you can really collect them is by having a person identify the cases through their own criteria. So for example, if you're trying to study a patient population who's not easily defined, i.e. you might say, oh, they're somebody with a certain personality and characteristics and maybe social circumstances and all these things which you can't really put down on a checklist and make it black and white. You just have to use somebody, an expert, to say, okay, yeah, that's somebody that we want to study. That's somebody we don't. That's called judgment sampling. The problem with this, of course, is that it can easily introduce selection bias. It depends on an individual selecting them out. But so that's only for circumstances where what you're studying is typically quite rare. And if you just collected a whole cohort, you would create a huge amount of work for very little actual positive cases. So when you're planning for data collection, you need to establish, determine, define, and designate. And it's pretty much self-explanatory. It's just going over what we've talked about. So when it comes to evaluate the results in research, it's quite often a before and after, and you have 2 bar charts, before and after, and then you'll have maybe some confidence intervals with some statistical testing to say that before and after is a different, is significantly different, and therefore what you did in between has made that difference. And if you've controlled for all the variables except the one you're testing, then the conclusion is that, well, it must be the thing that you introduced that made the change. But in quality improvement, we're not trying to prove the relationship between causation and correlation. We are trying to simply know, are we going in the right direction? Are things getting better? And we're kind of relying on the fact that whatever we're doing is probably making that change. But a better way to show that rather than a before and after bar chart is actually a time series. So that's what a run chart is. It's where we plot it either each individual consecutive individual on the x-axis, or we aggregate it into weeks or months or days or whatever, but we see a progression along the x-axis, and we see on the y-axis things going up and down. So run charts are really, really powerful to show trends, and that's what we're trying to measure in quality improvement. So as you can see, if you just presented that data in terms of just numbers on a chart like this, it's quite difficult to see what the trend is. Of course, we put it into a bar, into a line graph like this, and you can start to see that there's probably a downward trend towards the right-hand side there. And this is a typical run chart. You really don't need to be any more sophisticated than a run chart usually. And the reason being is that the people that you are showing this to are often not literate in anything more fancy than these anyway. You can use Shewhart charts, you can use Q-sum charts, which are statistically more sensitive at showing you that something is definitely changing. But when it comes to showing that to other people, committees, boards, and stuff like that, you really lose them as soon as you put on too much. So the simpler you can make a chart, and run charts are probably the simplest you can do, the better. You can have maybe those statistical things in your back pocket if some smart arse stands up at the back and says, oh, how do you know if this is statistically significant? So when it comes to using data for improvement in research, we really focus on getting a large set of data and proving something. Whereas in quality improvement, we want to actually do little small tests that kind of are not statistically significant themselves, but kind of just show the direction of travel. And that's where PDSA cycles come in. So you have to really start off small. It really is much easier if you think about the first PDSA change that is almost as if we were doing normal business. An example of that is when I implemented an abscess pathway, a day case abscess pathway in Canterbury, the first PDSA cycle was one patient. And I knew this would work. I knew it would be successful already because we were still, we had before already doing some patients as day cases, and like 5%, but it was absolutely possible within the system we had there and then that we could get a patient in and out in the same day and not spend a bed day in hospital after having an abscess operation. So, but I wrapped it up in the project, and we really made it actually intentional that we were going to make this patient a day case. And of course it happened. And that was our first PDSA cycle, but everybody got behind it and thought, oh, this is actually quite possible. It's easy. Let's do more of that. And that's how you build your momentum. There's a 5 times rule where the next step up you do something's about 5 times the size. So if you did one patient one day, then your next test might be a week, because a week's worth of patients might be about 5, something like that. Or you could say in an area, so I'm just going to try in one bed area, so maybe 4-bedded ward room, and then the next test you might say, okay, this side of the ward, and the last one might be the whole ward, and the last one might be the whole level or something like that. Oh, sorry, going backwards. So once you've got your results, once you've done your PDSA cycle and you look at the results, you've got to interpret them. And if the data shows improvement, very good. Okay, then you can focus on your next test cycle, building on that, improving it more. If it doesn't show an improvement, you go back to the drawing board and you actually say, well, what was wrong with it? What do we need to change? And if the data is inconclusive, then you probably need to repeat the testing, as is if there's a failure in the data collection itself, you might need to actually start thinking about, well, what data should we be collecting instead? So I'm just going to show you this short video now from this chap called Lloyd Provost, who pioneered a lot of this with the IHI several years ago. He's quite interesting because he's actually got a daughter who also is in the same field. And a couple of years ago, I was on a conference, and the 2 of them were presenting on run charts. And just beforehand, there was the typical daughter trying to show him how to use the technology in front of him. And it was really quite funny. Anyway, here we go. Oh, hang on. Sorry, I need to share the sound. 1 second. Audio. Share sound. Here we go.
When I first learned the frameworks for improvement and how you do it, we talked about really understanding the current system, flow charting processes, doing cause and effect, doing lots of surveys, getting all the information, getting ready. And so I, as I advised people that way and saw what happened, I saw a lot of activity but no improvement. So everybody was doing flow charts and looking at their system and collecting baseline data. And we realized in that talking to some people, as we work with some professionals, we see they got antsy with that. What is all this quality improvement thing? Why can't we make something happen? And so we went back and re-looked and rethought Deming's PDSA framework. And he said, why don't we just start running PDSAs right at the beginning? We could do it in parallel if we need to do all these things. And so as we developed the model for improvement, we made that sort of a framework of don't necessarily need all the answers before you get started, and and so the whole idea of what cycle can we run by next Tuesday became sort of a mantra as a provocation for people to think differently about the system. And it doesn't mean none of those other background things are important, but it means that we can actually get along and begin to learn something right away by starting a PDSA. And for a while that was in IHI's collaborative stuff, that was sort of a little mantra for us to get people. It's just a provocation that got people to think very differently about improvement, that we actually could do some improvement next week, even though we don't know that much about the system we're trying to improve. So I think that sort of changed the framework and made the model for improvement different than a lot of other frameworks that were available at the time.
Okay, so I'm going to put you guys out into some breakout rooms now, and we're going to just use that provocation and see, in your area, if you're going to do some improvement work and you had maybe a couple of hours spare, what could you do by next Tuesday? So I'm going to just create the breakout rooms. And it's just going to be random, and it's probably going to be for about 6 or 7 minutes. Okay, and then you'll automatically come back here and we can share some of our discussions.
Cancer nurse working in cancer care. I'm in an office with 3 other clinical nurses, specialists as well, and we do a bit of quality work in our roles. But doing something by next Tuesday, I think that would be just brainstorming for ideas in that short time frame.
So yeah, are you talking about actually doing something by next Tuesday, or just thinking about what can we do and starting the process?
It's something you can actually do, something you can change and test. And so it's obviously going to be something extremely small, because you can't do much between now and next Tuesday, but it could be something as noticing that the stocks of something are always out all over the place, and what can we do to level that out, for example?
So I work in public health, and we've just changed the notification process for COVID-related deaths with a new form. So we could look at whether that's made a difference to the information we're getting, but that wouldn't be something that we could do quickly, would it? or we could at least start that, but are you talking about something really small and quick that we have to complete by Tuesday?
Because I mean, it's stressful enough.
The trouble with public health is that what we do is quite slow to see change.
I'm not saying what you can do by next Tuesday that is proving a change. I think what it is, what can you start? What can you do? And then you might have to measure it the week after to show that it's made a change. But what change can you actually, plan to start next Tuesday? That's the provocation.
Okay. I've got an example.
I'm going to drop out. I'll leave you guys to it.
Okay, thanks.
Thanks, James. We've got person and see
because if they just glance, then they might not actually see if it's sitting up against one side of the cubby, or they might not glance in the right place. We're just talking about the RMO male outside my office.
Cool.
Yeah, I'd sort of always want to ask the doctors though if they even care about the male, because you're not going to get them to buy in if they don't. Like they sort of say, actually, 99% of it's junk mail. I don't care about it. So, yeah.
Well, it's on them. Yeah. We've got to have a place for it to arrive, because they've given the hospital as their address to all different kinds of organisations. So we've got to have a place for it to go. And it's split in house officer and reg, only for the departments that the RMO unit look after. And it's split into cubbies, A to B, B to C, D, and so forth. And that's because of the sheer volume of change we have through, the monthly cycles or 3 monthly cycles or year that we have the doctors as they move through their, throughout New Zealand. I email them if I see that it's getting, if one particular cubby is really full, I'll send an email out to, I'll sort through it and say these people, oh, look, by the way, you've got like 8 letters here. But like with all the clinical letters, if they dictate letters, then if they're getting sent a letter, then it's on the dictation system as well. So they'll get an alert. Yeah. I don't know.
It's an interesting problem. Yeah.
It is an interesting problem.
Yeah. Great.
Anyone else got a problem?
I'm going to join the other room for now. So welcome back. Everybody's popping back in. We'll just give a minute for the technology to work. Should be getting. Room 2 is still going, so they obviously deepen discussion. There we go. Great. So I've probably cut off some of your conversations. but such is the nature of Zoom. Maybe anybody who was cut off who wants to sort of carry on and maybe just explain to the group, the little problem that you were talking about. Or if not, anybody.
Well, we had a.
There we go, Sally. Yeah.
Sorry, we had a couple of things. Emma, who's a cardiology nurse, had a really good example of how they're going to, just by chance next week, look at some quality improvement. So
Not a nurse though, cardiac physiologist.
Sorry. Well, you're a
right.
specialist, cardiac specialist.
Yeah, we've got some new software. We have to sort of transition people into using some new equipment and new software. So we thought we'd try it on one patient first, just to get everyone used to it. Yeah.
So this new equipment, what exactly is it?
It's so we have a 24-hour ECG monitoring monitor, and then we have a 7-day one, which is where they press a button when they have the symptoms.
Right.
So currently we use 2 different brands and 2 different software packages, but one of them is now obsolete because it's on Windows 7. So we have a new one which is integrated with the other one. So we'll be able to use one monitor for both things and retire the old ones that keep breaking and you can't get anymore. But the software is new and so are the monitors.
Okay.
So we have to teach the patients how to put them on and teach the staff how to use the software.
What would you measure to show that this is an improvement?
Probably you could measure. No, I don't know actually. I'm just trying to think. That successful recordings would be good.
So the problem was unreliable recordings, some of them not recording properly?
Well, the patient has to attach the monitor themselves. So daily, because they're, if they want to wash, they have to remove the electrodes and put fresh ones on.
Right. And the outcome is that sometimes they don't reconnect it properly, or you just don't get a good recording?
You don't get a good recording. The monitors fail. So the new system is also on a server, which means you can access it from multiple places. So the outcome would be, I guess, the availability of reports could be something as well, because currently it's the one standalone, and so nobody has access to the strips. So the availability of the electronic reports will be quite improved.
So maybe one measure, which would be probably quite a hard outcome measure, would be, the percentage of recordings that are complete. Somehow, if that's an easy metric or something to show that your hit rate, your success rate from the recordings is better.
Yeah,
maybe another.
Currently, it's only a text report, whereas we will have the whole ECG report and the medical records electronically.
And then another sort of measure that might be also good is like a survey of some description for the staff who use it, to make it really good in terms of quality improvement. You wouldn't want to do just a survey once you've implemented it and say, oh, how is it compared to the old one? Because new shiny things are always better. You would want to have something you can measure repeatedly.
I guess the time spent, you could do the time spent. Maybe the new software might be more efficient. So the time spent sort of analysing, but I guess it depends how often the patient's activated their monitor as well.
Yeah.
So
but yeah, I think it's good to think of a way to measure the impact of your intervention, and this is clearly something that's required some investment of time and money, and so it's important to demonstrate the benefits of it, because also in any change you need to be measuring balancing measures. which are the unintended consequences. You will obviously pick up some problems with the system as well as good things. And by making sure we're keeping those balancing measures in check, you can make your whole project more successful, because then you can sort of actively mitigate some of those problems.
Yeah, we've already been doing that because of the amount of monitors we have is not going to work very well. So we may have to change the days we put them on.
Okay. Interesting. Great. Thanks for sharing that. Does anybody else have any things that they could do by next Tuesday?
I was thinking of the mail cubbies that I've got for the RMO doctors outside or in the RMO unit hallway. As you can imagine, sometimes they get a little bit full. We're hidden away in between the ward block and the sort of the historic hallway, just in that first sort of entrance there. And so we're accessible, but yeah, sometimes it banks up. And so normally if by glance I see that one's particularly full, I will email, audit it, have a look who's there, email them out. But then sometimes, there's a lot of global emails go out, so that still doesn't fix the problem. There's a fair bit of junk that they get, or what you would call junk, from promotional stuff and things like that. But yeah, I guess getting more buy-in, creating more care for their mail was one of the suggestions. Like, do they care about it? And so, yeah, just trying to think of the awareness. Is it on their mind to come and check?
And so the problem is the overflow of mail that just piles up there.
I think the mail that is left unchecked.
Yeah.
And like, I don't check it, so I don't know what it is. And I know some of them get clinical letters sent to them, but if they dictate letters, then they should be receiving an alert on the clinician dictation software in their inbox, because I'm med secretary for MedOnc as well. So I know that they do get a notification of all letters that are sent to them through that same system they use to dictate their letters. And so they can see them there, but yeah.
Yep. And I'm just thinking off the top of my head of things you could do. You could you could have a mail amnesty or something next Tuesday.
Oh, that's a good idea.
Yeah.
I'm going to write that one down.
Or maybe, and maybe even have like a big bucket or a shredder in the middle of the room, and some sort of reward for shredding your mail. Anyway.
Yeah, a bowl of candy.
Yeah, exactly. Okay, yeah. Thanks very much for sharing that, both of you. That was great. And I'm just going to move on to the last bit in the last 10 minutes. So this is a little thought exercise here. So a lot of you might know about what the Net Promoter Score is, but I'll explain it for those who've not that familiar. It's come out of business, and it's actually quite a good way to measure the temperature of your service in terms of satisfaction. And the question is something like, how likely are you to recommend us to a friend? So it might be like a family member. How likely are you to recommend this hospital to another family member or somebody who you care about? Or it might be a ward area, or it might be a clinic or something like that. Or sometimes in healthcare, you kind of slightly adjust and say, how happy would you be for your mother to be treated in this ward, or something like that. And it's a scale of 0 to 10. And people who are scores 0 to 6 are called detractors. These are people who will actively go out and actually say bad things about your service. 7 to 8 are passive. So these people are generally content, but they're not going to really go out and sing praises. And then 9 to 10, these are the people who will actually actively say to their nearest and dearest, oh, by the way, I went to such and such and it was wonderful. So you take the number of detractors off the promoters and you get a score. And generally speaking, you want to be positive. And to get up to 100 is really difficult indeed. And usually anything above 25 is pretty good. So it's quite a good measure. So there's your operational definition of taking that out of this little exercise. How you collect it is usually through surveys, or sometimes you have a little terminal at the end where people are exiting, or you have somebody standing there just asking them the question. But what I want people to try and answer is, how can we measure it? I've given you a couple of examples. And what cost zero ideas could we test? So thinking about your area, what things could you do next Tuesday that don't cost anything that might actually increase your net promoter score? And then how would you actually test it? So just spend a few minutes thinking about these. And if you could put in the chat some of the ideas. So for example, if you're ward area and you're the charge nurse on the ward area and you want to increase the net promoter score for the patients who are on that ward, how can we measure it? Well, one way you could measure it is by getting the ward clerk who typically will have some interaction with each patient during their stay, usually towards the end of the stay when they're getting ready for discharge, or at the time of admission when they're sort of like preparing all their admission paperwork. They could collect this information on bits of paper from the patients. I mean, for the patients, it really takes them 1 second to put in. And then this information could be put into an Excel spreadsheet. And then we can create run charts over time. And of course, that might generate too much work. So then you might think about sampling. So you might actually think, okay, we're just going to sample the first patient or the 10th patient of the day. Or typically you might just do like 1 day a week, or you might do it 1 day this week and then a different day the next week if you thought there might be some variation between the days of the week. But if you start to do that week by week, you suddenly get quite a lot of information quite quickly. And then, so what sort of cost zero ideas could we test? Well, we could these are changes to improve the net promoter score. One thing we could do is have a little prompt for nurses to maybe just ask an open question to the patient each day, like, how can I make your day a little bit better today, or something like that. And it, that is in itself is cause zero. They might not be able to do the request that the patient's asking them, but it's an interaction. It's a kind of an empathy thing. So that in itself usually leads to some positive feelings. So maybe just a campaign to get staff to ask a question like that of patients more often. Would that increase the net promoter score? And how would you test it? Well, then you maybe just do a PDSA cycle approach. So you might just ask some of the nurses to try it on just their group of patients for that day, like say there's 6 patients for that day, and then ask them how did they get on, how did that question work, and you would try and find out if that question was difficult for them, or if we could change the way the question was asked or when it was asked. We would also be testing the measurement of the net promoter score and seeing if there was more efficient ways to do it. And then the next PDSA cycle, once we gained information, we could start to like maybe do a whole week instead of just like one day, etc. So that was my sort of ideas. Just looking at the chat here now. So to have every staff member introduce themselves. Yeah, lovely. That's a great one. And actually that wasn't an international campaign, my hello, my name is thing. But it's something that you can really make a big difference there, to update whiteboards, to have staff ask what else you can do for you. Yeah, these are all cost zero things which do make a difference. So thanks for those suggestions. Does anybody else have any suggestions either on the chat, or if you want to unmute and talk through an idea of your own?
I don't have a suggestion, but I like the idea of introducing yourself, especially with masks on, because it's very impersonal at the moment when you see patients. You know, they don't see your face. I had a man yesterday ask me if then could I take my mask off so he could see my face, because he doesn't remember seeing me before, because we see our patients quite regularly, and he just wanted to check. So it's yeah, it's sort of putting a person. It's putting that person, you know, your own person forward to them. You're usually doing something quite intimate in a healthcare setting with the patient. So, you know, you know everything about them and they know nothing about you. So I like that idea.
Yeah. Yeah, that's a new problem, isn't it? That we're all wearing masks, and it is a barrier, isn't it? Maybe we'll be wearing masks for a long time. We've got to think of a solution to that. Maybe we should be all wearing bigger photos on us so that we can actually show what we look like.
And the some of the programs you see overseas, they have the badges with the faces on, smiling face, but they cost money. They cost money, so it doesn't really.
Yeah, no, I know. Yeah,
it's definitely the whole mask and social distancing thing is. Yeah, for administrators that don't necessarily work directly in the ward. In my medical oncology, predominantly typing role, we're located in a particular office. We go there. We're currently working mostly from home, doing our role, and come in one day for that and do typing and print them off and write the envelopes and things like that. But in terms of actually me knowing the reception staff, the booking coordinators, the oncologists, hematologists, radiation oncologists, and the nurse practitioners and social workers that I write the letters for. I think I've met the hematologists because I work on the same floor as them. And I've met maybe two of the oncologists, but I don't think I've ever met a radiation oncologist or anybody else. And it's only because I started the role just after COVID and back in 2020, and it's very like you're in your own little silo and you don't get to meet them. So a social aspect of my job is completely missing from the other years that I've worked in the DHB, where I've worked in old people's health and care coordination alongside NASC and at Queen Mary. And so there's quite social aspects of the job there. Whereas that particular role, I worked in my first year doing it about 35 hours a week. Last year, 20 hours, and I've knocked back to 10 so I can pick the kids up at school because I'm doing the RMO stuff as well. But it's a very hard place to be in.
Yeah, absolutely. Well, thanks for sharing that. We come to 5 minutes to, and I want to get you away on time. So yeah, in summary, make sure that you develop your measures that are easy to measure, not too laborious, and can actually show you what you're doing. You need to have a good idea of what you're measuring. You need to think about little things that you can do soon rather than trying to get everything together, and start off small and make sure you measure stuff throughout the chain so you can actually see what's happening, and you don't just sort of like go on sort of a hunch or a feeling. because speaking from data is far more powerful. Okay, so thank you very much, everybody. If you got any specific questions or any troubleshooting with the course itself, online stuff, I'll hang around afterwards just to troubleshoot with you. Okay, thanks very much indeed. Bye-bye.